I'm Dr. Cooper Williams. I'm here at the Jekyll Center in Thompson Station, Tennessee, and I'm here to present the pelvic ultrasound of the horse, both inside and out. I'm going to start with external pelvic ultrasound, and I'm going to relate landmarks on our patient here with our specimen here. When we're doing external pelvic ultrasound, it's usually in regard to a traumatic incident that the horse has sustained, and we're trying to sweep bone surfaces. Ultrasound is the most sensitive tool for bone surface detail, and we want to take advantage of that to outline all the bones in a traumatic situation. And I want you all to think in terms of survey, because you can find a fracture and then stop, and you might be missing the rest of the picture. So you really want to make sure that you sweep the entire pelvis when you're doing external pelvic ultrasound. The other situation that comes up is a performance issue where it might be related to a hip problem. So the hip joint will be included in the external pelvic ultrasound. But again, most of this is going to be related to traumatic situations where you're trying to eliminate the possibility of fracture. I'm going to start with the tubercocci. Here's the tubercocci landmark on our patient, and here's the tubercocci on our specimen. And I want to focus in on the end of the tubercocci because there's some very specific anatomy. There are four cuspids, if you think about it like a tooth. You have a dorsal cranial cuspid, a dorsal caudal cuspid, a ventral caudal cuspid, and a ventral cranial cuspid. And you're going to be scanning from above and looking at these cuspids, and we'll relate that to the ultrasound later, but I wanted to make sure that you were aware of the four protuberances of the tubercocci. The next palpable protuberance will be the greater trochanter. This is next to the hip joint, which you can see here. The hip joint is this portion, and this is the greater trochanter. And the greater trochanter is an attachment point for various gluteal muscles. And the gluteus medius, which starts at T17-18 up here in the region of the back, follows along the side of the back to insert here. The gluteus medius inserts on the top of the greater trochanter, which is this caudal portion. You have the cranial portion here, which is actually an attachment point for the gluteus accessorius. And here's the cranial portion here. The gluteus accessorius goes from the pelvis itself, the ilium, and crosses over the crest of the cranial portion of the greater trochanter to insert in this portion right here. And the trochanteric bursa resides underneath that attachment point of the gluteus accessorius. This is the caudal portion, cranial portion. Caudal portion, cranial portion. The next palpable protuberance that I want to review is the third trochanter. And it sits below the actual pelvis on the femur. I include it in my pelvic survey because it is a common part of the anatomy that will be fractured in traumatic situations along with other parts of the pelvis. So it's always a good idea to include this. On our specimen, you can see the third trochanter here on the lateral portion of the femur. It sits down about 5 to 6 inches from the top of the femur. And you can see on this lateral side of the femur how much it sticks out. So it's a common source of trauma. If the horse falls on their side, they will land on this preferentially because of how far it sticks out. And so crushing fractures are quite common here. You can see where this relates again to our patient. And just to show the patient and the muscle attachment, you have the superficial gluteal muscle, which starts here and here, the origins, has a membranous portion that sweeps across here. That muscle belly comes down, turns into tendon, and attaches here at the third trochanter. And so you're going to be looking at that tendon attachment as well as the bony protuberance here. Moving to the caudal aspect of the horse, the first thing I want to review is the fact that I use muscle symmetry to evaluate my patient. And it's a history book of use and abuse, and you want to use that to your advantage. And in this particular patient, we have the tuber ischium, which is our next caudal protuberance here. You have that outline in tape here, and you can see that on our specimen here. It's a pyramidal shaped portion of bone, and it's an attachment point for the hamstring muscles. But you can see that this side is much more prominent, and this is actually the normal side on this particular patient. You can see this one is actually crushed inward, and we'll confirm this with ultrasound later. But this symmetry needs to be evaluated and probably was traumatic. The tuber sacrale, the high point of the ilium wing, is a little higher on one side of this patient as well. But you want to make sure that you evaluate pelvic symmetry and muscle symmetry. it's going to give you a lot of clues as to what you may find later and how it relates. And again, turning to our specimen, you can see this pyramid-shaped portion of bone, the tuber ischium. This is, again, the attachment point for the hamstring muscles, and they only come from the ventral aspect. There's no antagonist muscle that keeps that bone in position. If you have an avulsion fracture, that will shorten the muscle belly and can cause gait deficits later down the line that are not pain-related, but can be permanent. But other than that, these particular portions of bone, when they're fractured, tend to heal up without any sequela later on. I wanted to review the final protuberance of bone that is a good landmark for when you're doing your pelvic survey ultrasound. These would be the tuber sacrale. This is our landmark on the horse, and this is where it correlates to on our specimen. So this is the high point of the ilium wing. You can see the ilium wing comes up to this high portion that actually forms what we call the croup of the horse. Tuber cocci here is the end point laterally. But this is an attachment point for a couple of different things. You have the dorsal sacral ligaments that attach here and come back to the sacrum, which is a set of 5 fused vertebrae on the ventral aspect. On the top, we have dorsal spinous processes. So those ligaments attach from here to here. The thoracolumbar fascia from the back muscles come back to attach to the cranial aspects of these tuber sacrale. But on our patient here, you can see that one tuber sacrale is slightly higher than the other, and there could be 3 main reasons for that. You can have a traumatic shift in the pelvis that actually drives one side up higher than the other. You can have a dorsal sacral ligament that is thicker on one side than the other from trauma to it, or a strain to it. And you can also have a horse that has chronic lameness that will be landing heavier on one side versus the other, driving the side that has the most pressure over time up higher biomechanically. And so you'll have those 3 main reasons for a higher tuber sacrale. Good to keep those in mind. But again, this goes back to the symmetry of the horse.